You're now live on YouTube, Chair.
Thank you.
Leave you to it. I'll just let Sue in, and then Sue was just arriving, so I'll leave you to it.
If you make me host, Gordon, as well, thanks.
Yeah, will do, no problem.
Okay, thanks. Welcome everybody to this governing body meeting for Rotherham CCG. We don't have any apologies, or do we, Lindsay? Nope.
Possibly Councillor Roach. I wasn't sure whether we'd be able to make it or not.
Okay. All right, but we are quorate. Are there any declarations of interest from any item on the agenda? Okay, we'll just have a quick round of introductions, and just so everyone who's watching knows who we are. I'm Richard Cullen. I'm a GP here in Rotherham, and I'm chair of Rotherham CCG. Ruth?
Ruth Brown, Assistant Chief Officer.
Okay, Janet?
Janet Weekly, lay member for primary care.
Simon?
I'm Simon McEwen, Vice Chair of the GP Members Committee and PCN Director for Health Division, Dearne Valley.
Okay, John?
John Barber, I'm lay member for governance.
Ian?
Ian Atkinson, Exec Place Director, Rotherham CCG.
Jeff?
Hi, Jeff Avery, GP and Chair of Members Committee.
Lindsay?
Lindsay Hill, minute taker for the CCG.
Okay, Ryan?
Ryan DeCosta, Secondary Care Doctor.
Chris?
Chris Edwards, Chief Officer.
Jason?
Jason Page, GP and Vice Chair of the CCG.
Debbie?
Afternoon, everybody. Debbie Twell, lay member for Patient and Public Engagement.
Ben?
Ben Anderson, Director of Public Health, Rotherham Council.
Jenny?
Jenny Lingrell, I'm the Joint Lead for Children's Commissioning for RMBC and Rotherham CCG.
Wendy?
Good afternoon, Wendy Allett, Chief Finance Officer.
And Sue, I've kept you to last because there's a couple of other things you just wanted to mention as well about what's happening today and next week.
There are. Thank you very much, Chair. Good afternoon, I'm Sue Cassin. I'm the Chief Nurse at Rotherham CCG, and I just wanted to remind everyone that today is International Day of the Midwife, and next Wednesday on the 12th, it's International Nurses Day. Annually, these are the days when we take stock, celebrate, and thank the professions for the care they provide and the difference that they make to all of us. This year, of course, we thank our colleagues for their extraordinary contribution to the COVID-19 response, and our nurses, midwives and care staff continue to make a highly skilled contribution to this. And also remembering that nursing is a global family and much of our workforce is international. And as a nurse and a midwife, I wanted to remind us all of that. Thank you.
Okay, thanks, Sue. Yeah, I think all the appreciation is being put up by all the other members of all the work the nurses do in Rotherham and across the world. And the midwives. Sorry, it's Midwives Day today. I should have said midwives first rather than nurses.
Midwives today, nurses next week.
Okay, that's fine. Right, are there any patient or public questions have been submitted? I haven't heard of any. I'm not seeing anybody mention anything. Okay, which means we'll just move on to the minutes of last month's meeting. Their accuracy and any matters arising, page 1. 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13 and 14. Okay. Thanks, Lindsay, that they're an accurate record. Chris, then, Chief Officer report.
Thank you, Chair. So I'll just go through item by item. So The first items are just an evaluation of the Macmillan Living With and Beyond Cancer scheme, which we've been undertaking as part of the South Yorkshire Integrated Care System. It's for a governing body to note. The next is the outcome of our, sorry for acronyms, I should say as well. SCE is Strategic Clinical Executive, which is our GP executive on the CCG. So each year we select a chair and vice chair. The committee has selected Dr. Cullen and Dr. Page as chair and vice chair for another year. So congratulations to you both. And that means that Dr. Cullen and Dr. Page will represent SC at the governing body as well. Just going down, in terms of transparency, there's been some contract extensions for 21-22. Obviously, we're in uncertain times, and because of the COVID arrangements, we've taken a pragmatic approach just to extend the contracts to allow us to expedite procurement rules effectively. So the contracts we've extended for a time-limited period are the Clinical Partnerships Limited for Teledermatology, the Connect Healthcare Community Interest Company Mental Health Primary Care Prescribing Review Initiative, and Helios Adult and Children's and Young People ASD assessments. And again, that's for transparency that they're in the report today to make sure that we do all our business in public. In terms of communication, there's an update on where we've been around key messages about help and support in a COVID-safe way in primary care settings as we look to hopefully unlock the NHS and hopefully start to tackle the recovery now from the pandemic. And also the vaccination programme, there's communications around that. The vaccination programme, I'm sure we'll cover it elsewhere on the agenda, but it's been a huge success in Rotherham, and absolutely thanks to everyone involved. And that's making sure we continue to finish up our vaccination programme, and the next stage is yet, as undoubtedly there will be as we move through. I will stop and take any questions, Chair, if anyone has any.
Any questions on this update from Chris? Okay, I don't see any hands up, so we'll move on to integrating care next steps update, Chris.
Yeah, so I'll go straight to the next agenda item under strategic updates because it all flows through, Chair. So I'll do the verbal update as part of that. So it's enclosure 8 in everyone's packs. So what we've got in enclosure 8 is a suite of documents which just need comment on the outputs from the governing body today, please. So the 4 things we have today is a health and care compact, which talks about values and behaviours in our system. We have a health and care partnership terms of reference. So our ambition is we'll have a health and care partnership working in shadow form during 21-22. There's a place development matrix. So when we say place, we mean our metropolitan boroughs, so Rotherham, Doncaster, Barnsley, City of Sheffield and Bassetlaw. So feedback and comments on that. And also we have a route map through 21-22, which will be our transition year, which will get us to a statutory footing of an integrated care system or integrated care authority by 1st of April 2022. So I don't know how you'd like me to do this, Chair. I'm assuming people have read through these, so I wasn't intending to go through and present all the papers. I wondered if we could go through document by document, Chair, and receive comments on the outputs would be my preferred way of handling, if that's okay.
I'm happy with that, Chris. I think, yes, everyone should have read it because it's...
So can we start with the Health and Care Compact? Can I just open it up for comments on that part of the document?
Yeah, so, I mean, did you want to just feedback, because we had the, had some feedback, we had the partnership, the place meeting this morning, so we had some feedback.
Yeah, so
in support of it this morning, didn't we?
So what we got was initial positive feedback on the document, on the Health and Care Compact. Each of our place partners will be taking it through their internal governance, and then the ambition is to take it to our place board in a month's time in order to do formal place feedback, and we have a deadline in early June to feedback. So initial positive feedback, but we're awaiting formal feedback from all our partner organisations.
Okay, so the feedback from here will go to that things. So I do need to hear some feedback from members of the group. Everyone's sitting there in stunned silence. As Chris said this morning, positive feedback is welcome. Debbie.
I'll start because you know me, I can't keep quiet. No, I thought it was a good document. It was clear. The 4 aims I think apply, doesn't regardless of your age, your gender, or anything to do with that. And I thought it was good, a good way forward as we all come together and agree the same modus operandi for us all going forward. Really, I thought the behaviours were right. Is what I'm saying. I think.
Okay, thanks.
Thank you.
No other comments?
So if we could just record that the governing body were supportive of the...
Janet's now got
sorry, Janet, are you trying to come in?
No, sorry, I pressed the wrong. Yeah, I mean, actually, all I was going to do was endorse what Debbie said. I think actually having something, sorry, I speak from long experience within the voluntary sector of us going around a compact and questioning whether we needed it and that. But I think it's really important to have something in place that does set out your principles and values. And I was pleased to see it. So that's it. It's positive feedback.
Thank you, Janet. Anyone else before we just wrap up? So I think to feed into the place board, Richard, I think I'm hearing is that general support for the document, and we'll feed that into the place, and then we'll respond as a Rotherham place to our ICS by that deadline. So thanks for that, everybody. We've got the health and care partnership terms of reference next. So how this will be, so in the new integrated care authority or integrated care system, we'll have an NHS board and a health and care partnership board. So I think the way that the policy's starting to shape up is the decision-making body will be the NHS board, and then the partnership board will be like a confirm and challenge advisory board. So this is an attempt to run it in shadow form to try and work out during our shadow year how it'll work in previous. So it's designed to be very inclusive. So I don't know if people have got any feedback on that terms of reference.
Okay, I'm gonna put John on the plate as our governance person, but luckily Debbie stepped in, John. But just like to hear your thoughts, and in terms of reference, as most go through AQUA and under your auspice, so you are our expert. But Debbie first.
Could I just ask a question, Chris? I did a quick tot up of the membership, the people involved in the partnership board itself, and I think I got to 56. Have I misunderstood that?
No, that's I got to 54, but I'm sure one of us is right. Okay. It's around that. It's around that area. Yeah, it's. I think, from my perspective, it's very inclusive. Whether that's practical to run a board in that way. So it may be something we wish to feed back is that we obviously respect the value of being inclusive. However, that'll need to be balanced with pragmatism about doing business. So
yeah, it could become almost unwieldy with that number, couldn't it?
But if we're doing a shadow year, that's something to certainly try out. So if everyone else is in agreement with that feedback, we can certainly record that and feed that back. It's about a balance, Debbie, isn't it?
Yeah. I mean, I appreciate everybody was represented in that membership, and rightly so. But it's just when you add it up, it's huge, isn't it? If ever we get beyond Zoom, I don't know where you're going to meet.
The football ground.
Yeah.
So thank you. If everyone else is in agreement, then if we were to record, the feedback is around getting the balance between being inclusive and being conducting business as a committee.
Okay. Ian, then Ben.
Yeah, thanks, Chair. Just one from me, Chris, in terms of feedback. Just on there is a section in the terms of reference around decision making. And I think it comes back to this is probably an iterative document that will have 2 or 3 different versions as it goes in that shadow bit. But I think the area of decision making needs to be furnished as we go along the journey, as we move towards an integrated care system. Because at the moment, I think that could be enhanced a little bit in terms of the responsibility for decision making in that group. Thanks.
Ben.
Thanks, Chair. Just to say, yeah, I think it's overall really positive. I think the interesting bit for me is how the sort of one board relates to the the 5 health and wellbeing boards, and I guess broadly the 5 boards will be aligned in their priorities, but will each have individual priorities of their own that will be different as well. I guess it's how the ICS and then place within the ICS all combine to be able to deliver joint plans at ICS level and at place level.
Okay, thanks, Ben. Simon?
Yeah, my concern a little bit with it is just, although it's inclusive, it's very big and unreal. It's more like a council than a board in a sense. And how would it make decisions if lots of voices are being heard? Sometimes the important ones will get diluted out. It's just how to keep it focused is one of the issues I wonder with it. I mean, it's good that it's inclusive and it's got so many people there, but if you're actually trying to make decisions, that could be counterproductive.
Okay. And then, sorry, I did put John on the spot, but John, anything from your position as the governance?
Yes, Chairman, thanks. I think the terms of reference as they stand are fine, and I think parts of the test will really be about how those ways of working are put in place. It's like Ian said around some of the things that we'll be doing around decision making, responsibilities and governance that need some oversight. One of the things that the 5 CCGs would like to do is to involve internal audit in looking at those as things develop, and the 5 South Yorkshire lay members for governance are trying to work together with the ICS on the development of some of that work as well.
Okay, thanks, John. Chris, is that enough?
Yeah, can I just summarise for the notes, just so we're clear? So I think the feedback is suggesting that the size of the membership does look on the high side, and we suggest using the transition year to see whether it's pragmatic in terms of doing business. We talked about how will you be clear on decision making and get a consensus with such a large group, and make sure that the agendas and of the Health and Care Partnership are aligned to our 5 health and wellbeing boards. So the key themes. Okay, so capture those. Thank you. I'll keep going. Next, it's a place development matrix. So just a quick background to what this is. So as we have a large ICS in South Yorkshire and Bassetlaw, we also have 5 places which have councils as well, unitary councils in most cases. The question is how do we get significant delegation down to our 5 places to allow local decision making and ensure the principle of subsidiarity is met? All the evidence shows that local decisions made as local as possible tend to be better decisions. So following that principle, we would wish maximum delegation down to our places, but obviously to allow that to happen, we could be talking about hundreds of millions of pounds here. There needs to be a place development matrix to ensure that each place has absolutely the appropriate arrangements to take on such delegation. So this matrix is like a development plan for places to be able to take on that level of delegation. So that's the background. That's what it's trying to achieve, the document. So if anyone has any feedback on the content, it'd be much appreciated.
Okay, feedback on this? John?
Yeah, Chris, it's really just about how we as a CCG enable the place to take on, help them take on those responsibilities. It's like the CCG is like reducing, the place is growing, and how do we make that change as a CCG? How do we help make that change in terms of what the place needs versus what the CCG has got, if you like?
Yeah, it's a good. I do understand what you mean. I think there's many skills within our organisation which will be required in the place-based arrangements. So in the transition year as a CCG, us absolutely trying to get as many of our functions transferred into the place, learning on the governance arrangements of the CCG. I do wonder whether particularly all the governing body members, but particularly the lay members, whether as we start going through and populating the development matrix, whether we have some sort of confirm and challenge session where independent eyes could see our self-assessment against it and help us on our journey to be a thriving place. So it's going to be an iterative process. I think we're expecting to complete, so the Place Board is expecting to receive a populated Rotherham response to the development matrix in a month's time. We'd expect to be with that a place development plan. And at the point we get to a place development plan, I'd suggest if I bring it back to governing body, and then governing body can consider how we can help with the place development plan, John. Does that sound appropriate?
Yeah, that's good, Chris. Thank you. Yeah.
Okay. Any other comments for Chris on the matrix?
So just as an action there, so I think feedback seems supportive, but as a recognition, there's a journey to go on. And as the place develops the development plan, we'll bring to governing body, and the governing body can consider how we can positively contribute to the development plan. Okay. Last one, don't worry. It's a route map. This is more for information, I guess. It's a Gantt chart in old language, a route map in new language. And it's just to show us key decision points to April the 1st, 2022. It will get further populated as national documents arrive. So we're expecting more national documents this month. There'll be a second reading in Parliament of the Act scheduled currently for June, and then we'd expect more guidance following that. So there's lots of steps still to go, but this is as of today, these are the ones we're aware of. So that's why it's trying to show us in a visual format.
Okay, thank you, Chris. I'm going to move the agenda around slightly because Jenny's been sitting there patiently. I was thinking about changing the agenda so Jenny was absolutely last because we don't really want to lose her, but and I'll say proper thank you at the start, but Jenny, this will be the last paper you present to us, so we'll go to your paper next. Thank you.
Thank you, Chair. I appreciate that. So I am bringing to governing body today for approval the SEND strategy and the SEND joint commissioning strategy. The main thing about these strategies is that it's important that we have them in Rotherham. It will be an expectation should we be inspected, and we are anticipating an inspection once they restart at the beginning of June. I think the other thing that's important to say is that these have been fully co-produced, and in particular the SEND strategy. And there was a big full day event that took place what feels like a long time ago now in November 2019. And these strategies have been in draft for some time, but due to COVID, we're just bringing them for approval now. Both strategies you'll see are underpinned by the 4 cornerstones, which are principles that have been in place in Rotherham and again were co-produced but now for 10 years and are endorsed by Department for Education and held up as good practice. So it feels important that we've got them at the heart of our both the SEND strategy and the joint commissioning strategy. And the other thing that we've sought to do is make the strategies very outcomes focused. In terms of accountability, so how are we going to progress the work? There's a slight difference. The SEND strategy talks about the different areas of governance and accountability and how that will be progressed and delivered. With the joint commissioning strategy, there are specific opportunities for us to work together across Rotherham Place to commission in order to achieve those better outcomes for children and people with SEND. I think just the final thing that I'll say is that from a needs analysis point of view in the strategy, important that the JSNA does capture children and people with SEND at the moment, but that we've tried to make that a richer picture within the strategy by including information we've got from children's education, health and care plans, and again capturing child voice and family voice very much within that. So it's just bringing them to you for any feedback and final approval.
Okay, Jason.
I'd just like to say what a brilliant job Jenny's done, and in bringing this to us. It's an excellent document, in my opinion, and I think the main thing that I've learnt from doing this piece of work or being involved in this piece of work is the vital job that Jenny has and then her successor going forward in because of the joint working between the council and the CCG. It's been a step forward from where we were several years ago when we didn't have such posts. So I'd just like to say thank you to Jenny and just endorse it.
Okay. Does anyone else want to say how great Jenny is? And you can comment about the paper as well. Debbie.
I would definitely like to endorse it. It seems a long time ago since you and I met, Jenny, to talk about this and what was going to happen in the future of SEND. So congratulations to everybody that's been involved in this partnership, like Jason says. One of the things I just spoke about, we were talking about this at Aqua yesterday, was I note from the paper that there's still some more work to be done with regard to transition pathways, because that seems to be an area that is very difficult. Transition is difficult for parents, families and young people and the agencies. I don't know if you've got any comments about that. Ian was very good. Yeah, we were talking about it yesterday, and Ian was sort of saying, yeah, it is difficult because, it's that difference that some partners that they recognise adulthood as 21, some of them do it at 18, some of them do it at 25. But it's not just at the adult end, is it? It's the transition at all stages, really, for these young people that are some of our most vulnerable.
I have got some feedback on that. So just because at an ICS level, they've now shared the priorities for children and people at an ICS level, and one of those is very much around transitions and an aspiration potentially to develop services that go up to the age of 25. So to very much have services for the 18 to 25 age group. I think the principle around that is not to create a new cliff edge at 25, but it's based on the fact that children by 25, young people are much more ready to access adult services because of that additional level of maturity. So my expectation is that actually there will be increased traction in this space when there's an opportunity to work across an ICS footprint.
Yeah, because I think it's important, isn't it, that transition time is where a young person moves perhaps from having things done on their behalf to actually being in control of what things they actually want to do in terms of their maturity sometimes. So, yeah, thank you.
Okay, any other questions for Jenny? Okay, so as a governing body, we're asked to endorse this paper. Is everyone happy to endorse the paper? I see nods and things and fingers up, so yes. We're happy to endorse this, Jenny. So we've endorsed it. Also, on behalf of the board and the organisation, thank you for all your hard work and wish you well in your future job. But we hope you'll remember Rotherham with fondness and feedback any good ideas you have so we can keep working hard. Okay, thank you.
Thank you very much. I've learned so much from working with everybody here today, so I really appreciate it. Thank you.
Okay, thank you. Right, just moving back to the agenda on to item 9 then, which is about the planning round, and we only do the first half planning round, but we can't make any football nowadays after Rotherham's result last night and the threat of relegation. So if we can keep it away from football for Rotherham's sake. Wendy, first half financial planning.
Thanks, Chair. So yeah, as you say, it is a financial plan just for the first half of the year. So we did just get a 6-month settlement. No news yet on what 7 to 12 might look like. And I guess the key points to note is that the financial regime that will operate is, I've covered it in detail in section 2 of the report. But just in the room, it looks remarkably like the regime for 7 to 12. In fact, it is that regime just with updates for appropriate levels of growth and some other bits and bobs. So it's a regime that you're already familiar with in that sense, which is good. Under that regime, our CCG allocation starts at 227 million, but it's then further increased to 249.8 when we add in pass-through allocations, which literally we get given because we need to pass them on to somebody else. And also when we've been notified of some additional service development funds that we were expecting, but they've arrived a little bit early. So when we add those in, that's how we get to the 249.8. And the detail behind all that is set out at section 4A. So we've done our usual, and alongside the available funding, we've modelled what we think our likely expenditure would be. So to do that, we start with the recurrent forecast outturn spend, and then we adjust for what we believe are appropriate levels of growth and inflation locally, and known cost pressures. And again, all that's set out under section 4B in the table there. But when we did that modelling, it initially revealed a gap that looked like 3.1 million. However, we believe that that can be reasonably mitigated from within the financial envelope that's provided. And that's because of the continuation of the regime in place. So we have some offsets currently in there. And essentially we're only then needing 700,000 pounds worth of mitigations that we would list as currently unidentified quip. And within that, we hope that some of that may be further mitigated by ICS development monies, should we get any slippage on that, especially towards the second half of the year. So for those reasons, we have been able to set a balanced financial plan. And I guess the risks to those plan I've listed at section 5, but they kind of fall into 3 broad categories, and it's that literally as crude as the expenditure allocations that we might be assuming don't materialise, but we're only assuming them because we've been told that they should materialise. So it feels like relatively low risk. The larger risk is that expenditure doesn't come in line with some of the growth assumptions we've made. And for us, as you know, that particularly always impacts prescribing and CHC. But there are other areas. And the third risk I'd just draw your attention to is the emerging magnitude of the risk in mental health and LD services, where we are seeing demands for services from our providers that are well in excess of even maximum levels of funding that we can carve out currently. So in terms of this plan, I'm just asking you to note that the governing body subcommittee, which was set up to oversee the production of the financial plan this year, has been through this plan in detail prior to it being submitted to the ICS on the 29th of April. And therefore the plan is here with governing body for formal approval. I'll pause there and open up to any questions if anybody has any.
Thank you, Wendy. John, do you want to just feedback from the subgroup that we're or anything?
Yes, please, Chairman. I think I'd like to really endorse what Wendy has said, really. I think this is a pretty robust plan for the first half of the new financial year, and it feels like one that should be deliverable for us. And just as an example of why I'm saying that, the efficiency savings requirement, the QUIP requirements, are lower than we've faced for quite some time, really. And I think that the mitigation of 3 million that was proposed by Wendy, it's pretty clear that the majority of that should be deliverable. The only element that's probably in doubt at the moment is the QUIP element that Wendy referred to. So I think this is a pretty strong plan to get us through the first half of the new financial year, and there's no reason why it shouldn't be deliverable. I think in due course we'll have to develop the H2 plan, won't we, Wendy? The second half of the financial year, and that might be a little bit more difficult, bearing in mind the mitigations that we've used in the first half year and the likelihood of a slightly higher efficiency gain requirement in the second half year. So I think a robust plan for the first half year. We'll need to come back to a second half year plan this year, which we're not used to doing, but we've still got that to do.
Okay, thank you, John. Any other questions for Wendy? Okay, so as governing body, we're asked to, where are we? Formally approve the fact. I just need to, with that check whether it's approve or ratify or whatever, or Ruth frowns at me. So we're here to approve the financial plan. Is everyone in favour of approving the financial plan? Okay, I see hands up, thumbs up, yeses. Okay, yeah, so Wendy, we've approved that financial plan. Thank you for all the hard work. Unfortunately, you're going to have to do all the hard work again for the second 6 months, but good luck for you and your team. Okay, moving on then to update on the planning guidance, Ian.
Yeah, thanks, Chair. This just follows on from Wendy's paper. You'll note this is a verbal update, colleagues, and the reason for that is just the fluidity of the planning round at the moment. So what I'll do is I'll just give a verbal position in terms of where we are with the other aspects of planning. So just to remind colleagues that we've been working on a planning round since what feels like the end of March, so a really quite tight planning round this year, 3 to 4 week period with our final submissions during this week, hence the paper not coming through, which we'll follow at a point, Chair. But there's kind of 4 components to the planning round. So there's the planning documentation that we're responding to, but within that there's the financial plan, which Wendy's described, and then there's 3 other parts. Our narrative in response to the planning guidance. There is an activity submission which reflects how the Rotherham Place is going to deliver expected levels of activity linked in the main to recovery. And there's a 4th element which is around workforce in terms of our available workforce across the Rotherham Place from a predominantly health lens across primary care, mental health and the acute sector to deliver the aspirations of the planning round. So just to confirm, the planning guidance in itself, again, focusing primarily on months 1 to 6 or half one, was really focusing on kind of 3 main areas. Those were kind of reset and recovery, working to make sure that we can manage surge should we have another surge of COVID in the system, and also to ensure that we deliver kind of key aspects such as the vaccination programme. So all our narrative in response to that planning guidance has been completed by partners and by the CCG. And that was submitted this morning. Our activity, which in the main focuses on acute activity and focuses on elective care, was again submitted today, so we'll be able to share that in the public domain going forward. And then the workforce returns across primary care, mental health and the acute have also been concluded just this morning, Chair. So they're all now being submitted up to the ICS, who will aggregate all that information together and make a submission by the 6th of May, which will become an ICS submission up to NHS England. So in terms of delivery of the ask, the Rotherham Place has done that. We'll get feedback over the next couple of weeks and be able to feed back to governing body in more detail in the public domain as we go through to the June cycle. So just wanted to make sure that all board members were cited on that, and I'm happy to take any comments or questions on the process. Thank you.
Okay, any comments or questions for Ian? Okay, I think we'll just start with obviously have a clearer conversation next month. We will. Okay. Okay, we'll move on then. Back to Wendy then. Finance and contracting performance report.
Thanks, Chair. I can keep this really short this month. It basically sets out that at the end of the year we delivered the forecast that you were all expecting, so 1,078,000 we came in at. And there really is nothing really much more to say given that we did it.
Well done.
Team efforts, as always.
Subject to finalising the accounts, obviously. When
well, absolutely, Richard. Yeah, I was being overly confident there, wasn't I? Yeah, subject to audit.
Well,
we have nothing to hide.
Just used to accountants. Anyway, John.
Well, just to follow up what Richard's just said, really, because it was the audit committee yesterday, and Wendy and the team have now turned the financial management report into the annual accounts, and we reviewed the draft annual accounts yesterday in some detail, and we got quite a lot of assurance about the appropriateness of those accounts, and as you say, they're going through the audit process now, and as a governing body and an audit committee in early June, we'll review the outcome of that work as well.
Okay, thank you, John. Any other questions for Wendy on this? Okay, thanks for that update then, Wendy. Moving back to Ian for the delivery dashboard.
Yeah, thanks, Chair. So as in previous months, if I can, Chair, I'll just introduce the bit on performance with a bit of a covering one on the COVID position, just because then it allows the performance to flow through. I won't spend lots of time on that, but like many other areas, regionally and nationally, we're seeing an improving position on our COVID prevalence in the community. down in the view of around, I think it was 44 per 100,000 last time we kind of received that information. I can see Ben's joined us from Public Health, so maybe able to comment further. So that's a really good position. Our hospital base in terms of COVID positives was I think it was 2 patients the last time I received information. I can see Sue nodding as well at that. So you can see from a layman perspective how the improvement in the position has been seen. The vaccination programme has again maintained its positivity in the Rotherham place. We're now seeing that over 70% of our Rotherham residents, registered Rotherham residents in the adult population have had a first dose, which is a fantastic achievement for us at this point in time. And we've also now seen that over 90% of the 70-year-old and above have now had their second dose in the borough, and that's getting closely followed by the 65-year-olds as well. And we are seeing really good position now on the 40 to 50-year-olds with over 75% having had first dose there. So you can see all this coming together is a positive position for the borough. We are targeting health inequalities within amongst that now, particularly in the central areas. And I know Ben may want to comment further when I've just kind of covered off this item, but some targeting of specific groups to try to make sure that we get that vaccine coverage to the same level across all parts of our borough. So that is good. Bringing then on to the performance and how the system looks in terms of the view coming out of the kind of recovery. A lot of this information you'll see within the report, Chair, focuses on the period coming out of March and into April. So not quite seeing the release, and some of the data actually is into February as well. So what I would say, and just by exception, as I always do on the performance report, you can see now that we are starting to see quite a stepped increase in patients attending A&E back to something like the levels that we had pre-COVID, and that's reflected in the performance report. That is creating challenge in our system in terms of managing the front-end demand, but again, we're putting processes in place to support that. I think the other point to note there is that we have got continued positive IAPT performance on mental health, which is good. However, you can start to see now in some of the performance information, which we're really trying to dig into and have dialogue with our service around those that are being treated and seen within 6 weeks, because we don't want to create bulges in our pathway. On the elective side of care, which links to the planning discussion, our referral to treatment starting to improve gradually, and we are seeing now elective services coming back online. There are quite significantly challenging ambition in the recovery of elective care noted through the planning guidance in terms of getting our activity back to 85% of the previous year's level by July. So our assessment of that is that will probably be deliverable in Rotherham. But what you will see in the performance is that our number of 52-week waiters is still very high. We had 929 in the previous month. That is now down to 745. And there is a commitment as part of our planning to get that down as close to zero by the end of the financial year, to really target those people waiting long periods of time for planned care. Our cancer performance, although we continue to focus on that, it remains challenged, as does other areas. And again, we maintain focus on cancer pathways. So those are the kind of key parts by exception out of the report. I just wanted to flag to governing body today, and as usual, I'll have to take any comments, or if anybody's got anything additional to add, now's the time. Thanks, Chair.
Okay, Debbie.
Just a couple in. One to do with A&E. Obviously, the numbers are creeping up now, and I know when we spoke prior to COVID, we were talking about A&E and the acuity that were coming through the door. You know, they needed to be there rather than just perhaps going there as a first port of call before exploring other options. So I wonder if you could comment on that. And then the second was about the diagnostics, which is there a reason that you know about in terms, it looks like we've got a bit of a blockage in terms of accessing diagnostics compared to some of the other hospital trusts and bits and pieces around the patch.
Apologies, Debbie. Apologies, I just left myself on mute. Sorry.
Okay.
So on the A&E comment, we are seeing across South Yorkshire and other areas the kind of increase in numbers coming back through. We are seeing quite a lot of kind of, if you look at the information data coming out, kind of some primary care type attendances at A&E, and also kind of minor injury type stuff coming through A&E. That's not unusual actually at this time of the year for us as we're coming through the April and into the May period. So that kind of reflects where we might expect to be at this time of year. So I don't think we're overly concerned about that, but we are, wherever possible, diverting away at the front door. We're using new methods via NHS 111, etc., to try to manage that demand and that flow through the front end. In terms of diagnostics, I'm not aware of our discrepancy significantly with other areas. I know we've historically performed really well on diagnostics, but it's just volume at the moment, Debbie, and just trying to get that volume back and to kind of chip away. I think there will be increasing dialogue across South Yorkshire around additional diagnostic capacity as we go through the recovery phase and planning to try to get our performance back to where it was previously. So, but if that helps, Debbie, thank you.
Is it like a bit of a hump in the carpet in terms of everything reset and refresh then? Is that what you feel it is?
Yeah, so what I'll be able to present once we've had feedback on our plans is activity trajectories across diagnostics and the elective specialties within the system. So then we can start and report where we think we should be versus what we've kind of put up the line in terms of our plan. Just not quite there at the moment. We'll be able to start and see that, like what does good recovery look like for us for the rest of the kind of financial year.
Okay, all right, thank you.
Thanks, Debbie.
Okay, Ryan.
Yeah, thanks, Ian. Just by way of feedback, and certainly in the context of the A&E attendances, which seem to be creeping up very slightly. I mean, we have to note that this time last year, we were having this eerie kind of silence around COVID time when a lot of the other kind of normal sort of pathologies were not presenting to A&E, and the wards were incredibly silent. There were only COVID patients coming in. So I think one of the things that I'm observing in the hospital is that a lot of the patients who are coming are actually coming into hospital with more advanced conditions, like, for example, cellulitis or you know, chest infections and things like that. And certainly locally, one of the things that patients are saying to us in the hospital is that they're finding it quite difficult to access their own GPs. And I don't know whether that is something that has been looked at, particularly in Rotherham. I mean, I can't certainly say for certain, but my own experience within our local area is that patients are finding it quite difficult to get appointments, and they are actually you know, perhaps presenting a bit later to the hospital.
Okay, I'll let Jason answer that because he has his hand up. What's happening in general practice? And answer your question. You can ask the same question as well. Can't hear anything, Jason.
I think his internet is.
Yeah, it doesn't look like you mute, Jason. We just can't hear you. Okay, I know, Ryan. I can answer in terms of our practice. We're seeing probably more patients than we've ever seen before. The demand out there is huge, and we are trying to catch up with all the chronic patients at the same time. But the demand out there is still massive compared to previous years. So yeah, people will be finding it difficult to general practice because there's so many people needing to get into general practice at the moment. David, you had your hand up.
I was going to feedback the same. I've been in my current position for 10 years, and it's probably the busiest and the longest days that I've ever worked in that period. It's kind of an interesting perspective, though, that across, I was in an ICS meeting around urgent care earlier in the week, and it was similar feedback from primary care that they are incredibly busy, as is the hospital. I think other areas have done some work around how busy primary care actually is, and it's often that they were suggesting it's a perception of busyness because of how things dropped off, and then whether we've actually gone back to levels of activity prior to COVID. And I think that may be really difficult to measure because I think the way that primary care is doing things is different. So a lot of our appointments may not actually be visible on an IT system or a booking system, but are actually hidden within patients' records because things are being done in a remote fashion, which may not correspond with an appointment ledger. So it's kind of an interesting thing. And I think the hospitals were reporting similar things. Something that maybe took them 5 minutes to do a year ago is now, because of PPE, social distancing, those kind of issues, it just takes people longer. So to process patients through the system is just taking a longer period of time, which then causes the backlogs to occur. But I think the whole system's very stressed at the moment with people presenting. And I think I agree that sometimes people are presenting late, but I think that's a perception that healthcare is hard to access rather than the actual reality. I think people need to be seen. We're bringing them in and seeing them. It's just sometimes things like cancers are presenting late at the moment as well, which is a real shame.
Ryan, does your hand go back up or?
Sorry, I just wanted to make a comment on that as well, because I mean, certainly within the hospital setting, my own perception in my own specialty is that a lot of the time when we are seeing people remotely, we are ending up having to bring them back for a face-to-face consultation. And that's purely because of the nature of the condition. It's incredibly difficult to diagnose something complicated over the telephone, and there are lots of visual cues. And if someone reports a swelling, you have to actually examine it. You can't really make that sort of an assumption. I think some of the other, even I would have thought that, and I'm no expert here, but certainly people like who have got depression have got non-verbal cues and things like that you would see, isn't it? And I think that's something which makes it quite difficult, particularly in the context of healthcare professionals. And I feel that is also impacting on the treatment times in the hospital, because we're having to bring people back to see them face to face. And although we are triaging our appointments through ERS, we are finding it quite difficult to make an initial diagnosis. Not in all the cases, but in quite a significant proportion of cases.
Okay. Jason, have you got a microphone that works now?
Well, I've changed my headphones. Can you hear me?
We can hear you now.
Yay, okay. I was actually going to answer Debbie originally, just to give her a bit of insight about the diagnostics. We had a report through to SCE this morning, Debbie, saying that at the Trust, the ultrasound department have actually cleared their backlog now. So that's good news, but their challenge at the moment is CT and MRI scan. So we were given an example, though, there was some really good partnership working where Barnsley and Rotherham are actually swapping some of that service. So they're doing we're doing some of Barnsley's ultrasound, they're doing some of our MRI. So it just shows how there's some really good partnership working happening, just to try and get through this difficult time.
Thanks, Jason. Any more questions for Ian? Okay. Ben, Ian was hinting very strongly that you might want to make some comments about COVID. Is there any, obviously this is a public meeting we'll be watching, are there any Rotherham messages you just want to relay out? Again, because it's a public meeting, any key messages?
Thanks, Richard. Yeah, I mean, just put in the chat the figures for today. So I think first thing to say is we're going really well in the right direction over the last week, and we're down to 33.2 per 100,000 overall case rate, and 2.9 per 100,000 in those over 60, and really starting to see the benefits of the vaccination programme. So I think putting on record from Director of Public Health that massive applause for all those involved in the vaccination programme is really important. And what we are seeing, we've accelerated our reduction over the last week compared to the other areas of South Yorkshire. I think that is testament to where we went early in the 40 to 50-year-olds, and that we are moving down the age range, because we aren't seeing a lot of disease at all in those that are in the vaccinated cohorts. But in the younger unvaccinated, around school children, and those that are in the 20s, 30s that are still unvaccinated, is where we've got high rates. So I guess the real pressure for me at the moment is, how do we get more of those 20-somethings, 30-somethings vaccinated before the 17th of May, because we will definitely see an increase in cases in the unvaccinated groups from 17th of May onwards. And vaccination is the only way to mitigate that. So I guess the key messages are to prepare people that will see that bump in the case rate. It will predominantly be in unvaccinated populations, and therefore much less likely to end up with severe illness or hospitalisation, but there will obviously be some, and some risk of long COVID issues as well. And I guess the other key impacts now are actually time off work and time out of school, and the impacts that they have on education and productivity. So just a real plea really that people do continue to social distance as much as they can after the 17th of May and beyond, and also to take up vaccination as soon as it's offered.
Okay, thanks, Ben. Right, okay, shall we move on? Sue, quality and patient engagement.
Thank you, Chair. I'll start with the safety and quality report. The report covers all the usual areas, and I'll just draw attention to a couple of areas and take questions if that's okay. So on page 5, there's a summary of the continuing work that the Foundation Trust are undertaking around mortality. And while still an outlier, the Trust continue to see rates fall, though it's not clear yet what the effects of COVID on numbers have been. Moving through onto the next page, there's an outline of next week's GP training event on safeguarding. We've all got over 700 people registered to attend already. That does include staff from our partners across Rotherham, as well as GPs and GP practice staff. On page 12, you see that the continuing healthcare team have now completed the backlog of assessments that built up last year during the first part of the pandemic, when supporting hospital discharge processes put packages around people very rapidly to ensure a safe, rapid discharge from hospital. And all those have now had a full assessment to assess their needs and put appropriate packages of care into there, be that short, medium or long term. The Foundation Trust updates further on in the report includes a summary of activity associated with the CQC inspections and progress against agreed actions, and also the joint work between the CCG, NHS England and Improvement and the Trust to complete a quality risk profile and agree areas for further work and support. The patient engagement and experience report, sorry, I'll just take some questions on that. I'm going straight through to if anybody wants to ask any questions.
Thanks, Sue. Any questions for Sue on that paper? Debbie?
Not a question, Sue. It's just, can you just thank your CHC team for getting that backlog down? Because I think that's a phenomenal amount of work that's been covered and has sort of happened. Well done to the team, really, especially under such difficult circumstances.
It's been a big piece of work, hasn't it, Debbie? Thank you for acknowledging that. And I will pass that on. And they took that on board as a team and with partners, it has to be said, across the Trust and our MBC partners, working together to both bring back business as usual, the new discharge process, and completing the assessments of all those people who've been discharged during the first part of the pandemic.
Yeah.
Thank you for that.
Yeah, thanks.
Yeah. Any other questions for Sue? Okay, so you can move on to the second paper then.
Okay, thank you. The patient engagement experience report, hold on a minute, I'm just having a few technical issues here. It has been mainly pulled together as usual by Helen Wyatt, who is the CCG lead for experience and engagement. You'll see that COVID remains at the top of all communications, and even when people are communicating about possibly non-COVID related subjects, COVID does come into communications. There's some feedback from a member of the Rotherham Older People's Forum who shared their experience of being in hospital for surgery. This feedback will be further explored by the forum. For this person, there was some mitigation in terms of the fact that they could make use of FaceTime etc. But the forum want to explore that not all age groups or all people would be able to access that, and some of the feelings of isolation due to visiting restrictions that obviously are there for the purpose of safety. There's a link in the report into a report that has been published by Healthwatch around public opinion surrounding the COVID-19 vaccine in Rotherham. If you want to read that, there are in parts some very small numbers which make that difficult to say that it's statistically relevant. However, there are some interesting points around the small number of people who say that they are resistant to vaccination or unsure about vaccination, that informs us and arms us in terms of being able to prepare or target certain populations. And there's still a vast amount of work going into the volunteer support to vaccination clinics, with approximately just under 3,000, 2,970-ish volunteer sessions filled up to the end of April. That makes over 13,000 volunteer hours into supporting that. Obviously, this is a team effort, a massive team effort with GP practices and people from the CCG, but the volunteer support, I think, is the thing that we've included in this report.
Thank you, Sue. Yeah, it is a fantastic effort, isn't it? Continuing fantastic.
It is from everybody. I think it's just that the volunteers, I think we were all quite surprised by the enthusiasm and the amount of people who want to be involved from that perspective.
Okay, thanks. Any questions, Debbie? Anything to add on that paper?
No, I think Sue's covered it. I mean, we've sent a letter of thanks on behalf of the CCG
Yes.
to every volunteer now to say thank you for their work in that vaccination programme. So we have acknowledged that. And just to add to Sue's one about Healthwatch, not only have they published a report, but they actually did a Zoom drop-in for ethnic and minority, targeting those as to why perhaps they were reluctant to come forward. And quite interestingly, I think it was about 70 people joined that Zoom call. And after the event, most of the people there that were perhaps quite hesitant, and that's why they were joining to find out, said that they would actually go forward now and have their vaccination. So that personal one-to-one reassurance, I think, worked really, really well. So I know everything else, I think Sue said. Thank you.
Any other questions for Sue? All right, thanks then, Sue. The GBAF, Assurance Framework, Risk Reduction Issues Log, Ruth.
Thank you, Chair. So Aqua had a development session in April, and following the outcome of the Head of Internal Audit opinion. And the spattergraphs that you can see in the covering paper came directly from that session, which has gone down really well. The GBAF, Risk Register and Issues Log, they've all been updated by officers. That update was then confirmed in a very good challenge session held by OE at the beginning of April. Aqua went through all these documents yesterday quite closely. Happy to go through them again today, Chair, section by section, if you want to do that.
Okay, let's just get some general feedback from John first, from what the discussions were at Aqua.
Yeah, thank you, Chairman. I think the first thing is just to endorse what Ruth just said, really, around the splattergraphs, because they're a good way for the governing body in the future to identify the areas for focus and challenge in terms of the GBAF, because the areas that are in red and orange are the ones that we probably should spend more time on in terms of our understanding and our challenge around the GBAF. We talked a little bit about the O2 and the strategic objectives and how they might change and develop as we hopefully come out of COVID and command and control, and how we're now working in both an environment where there's an expectation of improvement. Some of the things that Ian was saying earlier on about the plan and the expectation that we deliver improvements in waiting times, performance, etc. So we want to try to make sure we have a methodology for planning and tracking that expectation. we talked a little bit about some of the things in the risk register as well, and we got good at Aqua. We got good assurance that the risk register is being maintained and developed in accordance with our policies, and that's working effectively. I think in terms of the financial aspects as well, at section 3.4, we reflected on really the situation in terms of how, given that ICS are taking a bigger role in terms of the overall financial plans and policies, we do need to understand more the financial position of the whole of South Yorkshire rather than just ourselves, because it can have a greater impact on us than perhaps it used to do. And finally, we just talked a little bit, again, as part of strategic objectives, just around one of the points we were talking about earlier under item A, about the development of the place and how we can sort of see that in the strategic objectives and how we might help and facilitate that. So there was sort of like quite a number of areas there, and I mean, I think we've made a good start now in this new financial year in terms of the management and monitoring of the GBAF, in terms both of the work that operational executive has already done, that Ruth described, in terms of holding the audit training and trying to make sure that audit carry out their role and responsibilities appropriately. And now here at governing body, getting ourselves geared up for that process of regular review of the GBAF as the year goes on.
Okay, thanks, John. I mean, I think as obviously the public governing body, when you look at these photographs, we've got a few in red. I mean, it's just for anyone watching things, can we just go through the ones in red just to explain what they're about and whether we've already discussed them in a bit of elsewhere in the agenda or what's happening? I'm sure if an officer can take some of them or...
Sorry, Chair, can I just clarify? You're talking about you wanting to go through the objectives with the risk above the risk appetite level?
I just think from someone in the public who's watching this for the first time and has these documents, they can see things in the red. Okay, so we've got the first one is 0.2, and this is around the CCG delivering its strategic objectives. So the risk appetite for that currently sets at 25, and this risk score is in red at 25, the same score as that. Chris, Ian, could either of you speak to that one, please?
So I'll go first, Ian, if you want, or do you want? So obviously our strategic objectives were set prior to the pandemic. So when we've been through and assessed the risk levels we have, the chances of us reaching our aspirations in terms of waiting times, of access targets, of reducing health inequalities, it's very difficult during a pandemic scenario, hence the risk. So obviously we'll have a recovery plan, and then we can reassess when we've formed the recovery plan as to if it meets the requirements to reassess the score, but that's the current status of that.
And a lot of that will be reflected in the performance reports then, Chris, in terms of the delivery dashboard and things.
Yeah.
Yeah.
You want me to come in on the second one on there as well, which is the objective, the second one that's flagging there, which is the objective 1.2, which is linked to that. It's around the elective recovery of elective care. So they all link. So John, we did have the discussion in Aqua yesterday, didn't we, John, around this, just in terms of as we reset and recover. So currently that's above our risk appetite, so flashing as red, but it's green in terms of our oversight and knowing our business. But I think what we're trying to say is that at the moment, as we are understanding the system, having coming out of COVID and setting plans as part of our planning round to say what that will look like in terms of recovery, that's why that one maintains itself at red. I'd hope that as we go along the journey over the next 9 months, that then kind of reduces its kind of risk level as we start to come back on track for elective care and our recovery, and we deliver against the aspiration of the planning guidance. So that's the rationale for it being in red currently, Chair.
Great, thanks. So I just wanted to make sure people watching understood why.
Yeah, absolutely. No, that's fine. No.
Okay. And I think the key thing being that we sometimes don't discuss them because they come in under other sections of the monthly report. So we are monitoring them in a different way as a board. Sue, you had your hand up.
I do, and it was more of a general comment, really. I just wanted to comment that I mean, I see it as a real positive thing that as an organisation and a governing body, we have a real golden thread of quality running through all of these things on our GBAF. And as we move forward and transition into other arrangements, I wouldn't want to lose that real focus on quality in its broadest terms as safety outcomes and experience. And even where it's not under the section of quality, you can see under transformation, there's still an emphasis on quality.
Thank you, Sue. So is there anything else today that, Ruth, we need to do with the GBAF or the risk register?
No, it was for review. So if you're happy with that review, that's great.
We got the assurance from Aqua, so I think, is anybody want to say anything else? Are we happy with that? And maybe we just, each time it comes back, pick off some of the orange ones just to explain how we are monitoring those ones that are over our risk appetite. Just so that anybody watching can understand how we are monitoring them and adjusting to them. Thank you. We stay with you then, Ruth. Incident management policy.
Thank you, Chair. So this policy is a multi-author policy with health and safety, information governance and corporate all being involved in the review of it. It hasn't made that many changes to the policy, and we wanted to do a little bit of tinkering to the policy in line with good practice guidelines, which included updating the IR1 form and adding an IR2 form and expanding the risk definition, which we have done. It was approved by Aqua last month and it's here for ratification today. Happy to take any questions.
Okay. If John, Aqua were happy with it?
Yes, Chairman. I think we just reviewed, we just reviewed under analysis of key issues and risks, the reasons for the changes and the improvements in the policy, and we were supportive of it, yeah.
Okay, that's great. Any questions or comments? Sue?
Just a brief one, and it was just in case anybody noticed. I mean, we did have an IR1, an IR2 form previously, but it was very brief. It was very difficult to make it meaningful or to fill it in, and this is to improve that part of it.
Okay, thanks, Sue. So, if there's no more questions, as a governing body, are we happy to ratify this policy? I take silence and thumbs up as assent. Yeah. Okay. Then we have the Primary Care Committee Terms of Reference. Ian, your initials are against it. Is this for you, Janet, rather than Ian?
Sorry, Chair, I've got myself off mute now. I'm happy to take it in if you want it, or it's.
You can do, Janet, if you want.
All right. I can't find it on my computer now, but I can remember it anyway. It went to Primary Care Committee in November. The changes in terms of reference were just updates really around changes in membership, changes of title, so changes like change the executive lead and just change them within that, and adding the executive place director. It went to Aqua yesterday and it's here for approval. I don't think there's anything. Is there anything else to add, Ian?
No, that's how it is, Janet. Thank you.
Okay. John, Aqua happy with it?
Yeah, yes, Chairman. I mean, I think we really noted that most of the changes relate to membership, didn't it, Janet? So I think we were convinced about that.
Okay, thanks.
Yeah.
So, as a board, are we happy to ratify this? Again, I see thumbs and hands up and yeses and nods. So take that as ratified. Thank you. Okay, moving through then the minutes from other meetings. We'll stick with you then, Janet. Anything to bring up from the Primary Care public minutes?
Thanks, Chair. These are the minutes from the March meeting. I think I'm happy to take any questions. There's just three things I'd just highlight. One is that we agreed some proposals regarding extended access and home visiting. We had an application from Queen's Medical Centre around to amend the practice boundary, and also we agreed the principles for general practice and local funding arrangements for 21 to 22. I'm happy to take any questions.
Okay, any questions for Janet? Okay, moving on then. Debbie, engagement comms.
Yeah, thank you, Chair. This was the March meeting. We meet bi-monthly. A lot of what we've already talked about this governing body meeting, we talked about vaccination volunteers and the vaccination programme. We also had a big sort of focus on the support for mental health that's going in across the borough, including the suicide prevention, Rotherhithe, public health, etc., and picking up on eating disorders, which I think is now becoming a bit of a national conversation, and obviously bereavement for people that have suffered bereavement during the pandemic, all based around what strategies we're putting into place with regards to prevention and support, really.
Okay, thanks, Debbie. Any questions on that? Okay, any delivery board, Ian?
Yeah, the information, Chair. I think the only thing that I would just flag to governing body on these minutes is the item 2.2, which was around the urgent emergency care clinical standards that were out for consultation at that point, and we're waiting for feedback now. But these are the standards that TRFT as an organisation have been working to for nearly a couple of years now, which are the emerging new standards for urgent and emergency care. So we'll wait for national feedback on those, but there's the direction of travel that they'll be adopted at a national level at some point in time, and it's indicated in the guidance, national planning guidance as well. So if governing body members just want to look at that section of the minutes, it just talks you through what the emerging themes are. If anybody wants to look in more detail, it's part of a national consultation that you can access via the NHS England website. We'll probably do something with governing body once that consultation's concluded, just so that everybody's aware of what the new standards look like and how the system will be monitored going forward. Thank you.
Okay, any questions for Ian? Okay, Aqua minutes from March, John?
The only thing I wanted to make the government body aware of was that we've agreed the internal audit plan for 21-22. It's quite a flexible plan, really, just really reflecting the existing ways of working and the future governance arrangements and COVID and the emergence of ICS. So, you know, it's quite a flexible plan to enable us to respond to things during the year.
Okay, thank you, John. Any questions for John? Okay, HEG minutes, Chris?
Nothing to raise by exception, Chair, but happy to take questions if anyone has any.
Okay, any questions for Chris? Okay, then Jeff, Members Committee. Have we lost Jeff? He's, oh, yeah, no.
I think he's frozen, Chair. Simon, are you in a position to take it?
Yeah, March meeting, plenty of referrals, but I don't know if anyone's got any questions particularly.
Okay, any questions for probably Simon, because Jeff's connection is a bit bad at the moment.
Can you hear me now?
Just about, yeah. There's no questions, Jeff. Thanks.
Can you hear me now?
Yeah, we can. Okay, no questions, fine. Okay. Right. That's bringing us towards the end of the meeting. I haven't been informed of any other business. Anyone want to raise any future agenda items? Okay, there's nothing.
Chair, the only future agenda item we covered was the place development plan, wasn't it, when it's available for the governing body?
Okay, yeah, thank you, Chris. Any risks raised or urgent issues? I don't think there was. Okay. And then we just have item 29 for the exclusion of the public. The representative of the press and other members of the public will be excluded from the remainder of this meeting due to the confidential nature of the business to be transacted, publicity on which would be prejudicial to the public interest, which we will start soon. Which brings me to the end of public meeting. Thank you very much for watching. The next meeting will be on Wednesday, the 2nd of June.